Thank you. Okay, a warm welcome everyone to our eHealth Learning podcast, a space where we encourage the sharing of knowledge and the support that brings. Thank you all for joining us today. Today I'm talking with my guest Beth Harrison, clinical lead pelvis health physio at Allied Health. I've asked Beth to join me in conversation today to approach intimate conditions that can often leave women suffering in silence. If you have any questions for Beth, please do put them in the chat box and we will put some time aside at the end to answer those questions. But actually, saying that, if anyone does feel that they'd like to raise their hand while we are in conversation, we will welcome that today because we are going to be covering quite a lot. So welcome everyone. Welcome, Beth. How are you today?
Good, thanks. Hi, everyone. Nice to be here.
And where are you?
I am currently in Hertfordshire, but I work in Suffolk.
Okay.
Yeah.
So you have a bit of a commute?
Yeah, a bit of a commute, but I'm used to it now.
Okay. So I did mention who you worked for, but maybe you'd like to clarify that because I may have just skimmed over it a little bit. So yeah, for our audience.
Yeah, so I'm a chartered physio, specialising in pelvic health. I've been a physio for quite a long time. I think I qualified in 2006, but specialised into pelvic health about 10 years ago. Previously to that, I did quite a lot of musculoskeletal work and others as well. And I've predominantly worked in the NHS, although have done a bit of private work over the years. But I'm now working for a company called Allied Health Professional Suffolk, which is a social enterprise or community interest company. And we provide NHS care in the west of Suffolk, and from my perspective that's for pelvic health. So we see a combination of both male and female patients, but it's predominantly female.
Okay, because when we talk about pelvic health, I guess the broader kind of umbrella that we often discuss is pelvic floor. So there can be all sorts of issues, can't there, that kind of arise out of maybe pelvic health weakness or, I don't know, malfunctioning, let's say. So sometimes those issues can, I don't know, have some kind of shame around them. So people don't mention it. Do they, and it can be quite difficult for people to kind of grasp. And those conditions can kind of come around not only through childbirth, but maybe the job you have or, all sorts of, stuff that you have to deal with daily. So I'm kind of interested in kind of talking around what those issues might be and how we'll focus on women today because I think that feels important, and how women can kind of, get that help. So symptoms we might be talking about could be prolapse, could be urinary, and how we learn to function with those issues on the daily and what might be supportive for that.
Yeah, so we do see a huge variety of conditions and symptoms, but actually, interestingly, we recently did some statistical analysis of the main problems that we see in our caseload, and it's predominantly urinary incontinence, of which there are two kinds, which I can come a bit to more. And then secondly, pelvic organ prolapse, which again I can speak more about. And then we also see, I think, an increasing amount of bowel dysfunction. So that sort of covers a combination of fecal incontinence and what we call urgency, but also constipation. And that, I think, we're probably seeing an increasing amount because there's a growing awareness of that, not only within the general population that there's help out there, but also other health professionals who might not have imagined that, physio, for instance, was involved. And then the other smaller area, but I think of equal importance and can be really affecting to people's quality of life is an umbrella term of pelvic pain. So that will include disorders such as something called vulvodynia, which is essentially pain around the vulva, vaginismus, which is sexual dysfunction, but even problems just using tampons and having smear tests and things like that. And then sort of other pelvic pain, which may go alongside other conditions such as endometriosis, polycystic ovaries, possibly other chronic pain conditions as well. So there's quite a variety of conditions that we'll see, and some are definitely more predominant. As I said, I think there's a growing awareness and I think less shame than there has been historically around speaking out about these problems, but I still think there's an awful long way to go, really. We know, and this is the patients that, you know, people that we know about, we know that probably 1 in 3 women are experiencing urinary incontinence at some point in their life. 1 in 10 fecal incontinence, and probably similar numbers, 1 in 3 or so prolapse as well over the course of their life. So these are really high numbers, and obviously that's to very varying degrees, and many people are just getting on with their life and kind of, you know, maybe not troubled by it enough that they seek help or don't feel they can seek help. But, you know, some of these conditions are obviously really quite debilitating, and often they also go hand in hand as well. So we're seeing patients with multiple problems, of which, you know, they're all having their significant effects and, you know, affecting people to such an extent that, you know, they don't even want to leave the house sometimes, which you can imagine is horrendous to hear. But equally, it does make it an amazing job, because you meet some incredible people who are dealing with an awful lot, and, you know, for them, hopefully we can offer them support and help that they either didn't know existed or they didn't feel was going to be helpful. And you can, even just offering advice and you know, signposting them to other appropriate resources and support can be potentially life-changing, I think. Hopefully, anyway. That's our aim.
Well, that's, you know, that's why that kind of information is really important, because if you are suffering with multiple conditions, it's kind of like, where do you start and what do you do, particularly when you have a busy life, or you know, I think sometimes it's easier to put up with something, but then one condition might be impacting another. So then so things are then becoming more and more difficult. And you can kind of, you know, when you were saying about how there is more acceptance, we're seeing on the television, aren't we, that there are adverts for pants that you can wear and all of that kind of thing, but I actually find them quite insidious in a way, because the women kind of do have all this joy around them, and it's like, well, you know, I know you need to sell your product, but actually I don't know how relevant that is actually to people.
I think that's the thing. I think they've used that strategy because they know the general sort of environment is that we are talking about things a bit more, so they're almost using that as a means to sell more products. I think it is frustrating because, yes, we absolutely welcome people talking about it, but in our sort of world we use the phrase common, not normal, an awful lot, because, you know, we're talking about the numbers that it's incredibly common, but it doesn't mean it's normal. You know, the number of women that I see who might come to me about one condition, and then I'll ask them about their bladder, for instance, and I'll say, and, you know, do you leak if you go for a run, or if you jump up and down, or if you cough? And they, or I'll ask them first, do you have incontinence? And they'll say no. And then I ask them that, and they say, oh yeah, but, you know, I've you know, what do I expect? I've had a baby, or, you know, it's just, oh, all my friends do. So they've kind of been conditioned to think that this is something they have to just put up with. And it's really not. It's something that can be solved. It's something that you can seek help for, and it's something that we know there is evidence-based approaches to, you know, to help improve things.
Yeah, and I think that's the important and empowering kind of aspect of it, is that you don't the pants kind of become the last resort. No, it's like actually there's a lot that can be done before that, and once you know what you're looking for, and once you know where to find it. So sometimes we talk about the pelvic floor, but actually, are we in relationship with that? Do we know where it is? That has to happen before you get to the pants, I would say. Yeah, what would your advice be?
Sorry, you cut out in the middle there, Natty, but I
Oh,
think I got the gist. Yeah, I mean, I would absolutely say, yeah, okay, it's great. I'll definitely encourage people to buy the pants, etc. But yeah, you'll never, something else I hear is often, oh, am I too old to make, to improve things, or am I too old to change things? And you are never too old we're never too old to strengthen our muscles, for instance. And yeah, you're absolutely right. The pelvic floor is quite involved, particularly with incontinence, and particularly with what we refer to as stress incontinence. So when we talk about incontinence, we talk about two kinds, particularly urinary. We talk about stress incontinence, and that's incontinence when, for instance, you cough, sneeze, jump up and down, move around. It's when there's an increase in pressure in your abdomen, and so that relies quite a lot on the pelvic floor closing, providing like a closure mechanism. The other kind of incontinence is what we refer to as urgency, or is often called an overactive bladder, and that is whereby somebody is needing to go to the toilet more frequently, and they're feeling like they can't hold on, and sometimes they're leaking on the way to going to the toilet. Now, the pelvic floor is implicated in that as well, because it has a reflex action on the bladder. It can tell the bladder basically to pipe down when it doesn't want it to open, but there are other things involved. So it's not only the pelvic floor that is important in these scenarios. But it is key. It's definitely
yeah.
key.
Could you just say a bit more about that? Because I think it's really important to know what's going on there. So yeah,
Yeah. So the
elaborate.
pelvic floor is a group of muscles. So it's not just one muscle. It's a group of muscles that work collectively. They wrap around our front and our back passage. So they blend with one of the anal sphincter muscles as well, which is why they're also really key in controlling bowel incontinence or bowel continence. And basically, there are two, a lot of the muscles in our body, they have a tendency towards two different sort of components of muscle fiber. One is type 1 and one is type 2, and that basically means that some of the muscle fibers are better at sprinting and some are better at endurance, and as we age we tend to lose more of the sprinting muscles as well, so we can sometimes see as we age we have less ability for that sudden control and power required, for instance if we do jump up and down, but for some of us those muscles are not working as well as they might. And as I said before, it's not only the pelvic floor. There are also there's a sphincter around the urethra. There's also something called fascia, which is connective tissue, which also provides support and stability. So it's not the pelvic floor on its own, but the pelvic floor basically can close the neck of the bladder and the urethra when we don't want it to open. And as we age, unfortunately, after our mid-30s, as you may know, we're losing muscle mass in all of our muscles unless we're actively sort of training to avoid that. And that happens as we age, and that will affect the pelvic floor in everyone to a certain extent. And also the key thing that we see for women is changes at certain times of life. So one of those being having children. And that can obviously provide its own trauma, but also affect our hormonal levels. And just being pregnant puts a degree of strain and pressure on those pelvic floor muscles. And then the second time is as we age, but specifically as we go into perimenopause and then menopause. And we know that estrogen in particular, the hormone estrogen, is very beneficial to our pelvic floor, our pelvis, our bladder, basically everything there, as it is to an awful lot of our body. And when those levels start to fluctuate in perimenopause and then decline, and the further away we get from perimenopause, or premenopause, the greater effect that can have. So that is often why women may have, for instance, had children, potentially had some trauma to their pelvic floor or weakened it, but essentially been okay for quite a number of years, and then they start to see that problems either emerge or they worsen around that time, and that's in many ways related to what their hormones are doing, as well as the fact that we're all aging, obviously, gradually.
Yeah, so those combination of factors, really do make. I mean, the changes can be remarkable, can't they? And we're talking about a kind of loss of control. Aren't we, in that sense? So things that would have normally have just happened naturally, you don't have to think about it. Suddenly you have to think about it. It's like, I'm not going on that trampoline.
Absolutely. And we know a huge barrier to women exercising is their pelvic health. And that's, we know the benefits of exercise to our well-being, our physical health overall, everything, are so huge. So if we're not exercising because we're leaking, for instance, then that has huge implications potentially on our well-being generally. So it's something we really need to address and educate women about, and help women so that they can continue to do those things that they enjoy. So many of my patients are avoiding, they might be going out going out the house, but they're avoiding doing quite a lot of activities, and it can be really debilitating. And it's not just the leaking with the stress incontinence, the urgency. I've got patients who are going to the toilet multiple times an hour, and they're not sleeping at night because they're getting up to go to the toilet so many times. So it's really affecting their quality of life. They're having to essentially map where toilets are in their mind if they go out and about, if they go shopping, and that's not okay, is it? That's not something they should have to factor into every aspect of their life.
Yeah, which is why kind of stress in the beginning of incontinence kind of covers, both the kind of mental and the physical stress of that, doesn't it? Like you say, it's so limiting. So when someone is coming to you into your clinic around, with those issues, and you're kind of introducing to what they might be able to do in order to kind of gain some control, what sort of advice would you be giving them?
So obviously everyone's individual, and it will very much depend on their overall health and any other health conditions that may predispose them to these problems, etc., and their general health. So we'll give them some obviously general advice on that front as well, and in terms of exercise. But specifically with regard to their bladder, it will depend on whether it's predominantly stress incontinence or urgency incontinence, if we're talking about the bladder, and very commonly those things do go hand in hand. So like, they are separate conditions caused by slightly different things, but we often refer to it as mixed incontinence, because somebody might have a combination of stress incontinence with a bit of urgency as well. So if it's predominantly stress incontinence, we will absolutely focus on what their pelvic floor is may or may not be helping them with, and obviously this is it's potentially a very sensitive area, so we have to be very careful. But we will very commonly and normally, as a matter of course, offer the patient a vaginal internal vaginal examination, and that's the best way to examine the pelvic floor, because obviously the pelvic floor is internal, so it's not like, you know, your biceps that you can see. So with the best will in the world, we can absolutely hypothesize that what is probably going on with their pelvic floor. But the best way to do that is to check, and we can do that without using a speculum, say, you know, as that you have if you go and have a smear test. We can do it with a gloved finger. Obviously, we're very sensitive about that, because a lot of patients won't want to consider that. They can have a chaperone, etc. But if they're happy to have that, then we can quite easily then assess what the pelvic floor is capable of doing. Because one of the things we have to be mindful of is we talk a lot and we hear an awful lot about the pelvic floor being weak. And that's absolutely can be the case. I mean, we tend to refer to it as dysfunctional, because it just sort of gives us a bit more scope. But what it can also be is actually overactive, which might sound strange, but that is actually more of a common problem than you might think. So somebody can present with symptoms that we would think they'd have a weak pelvic floor, so they're leaking, but actually if their pelvic floor loses the ability to be able to relax and let go, and that's something that it should just be doing without us telling it to, because obviously our pelvic floor is working away on its own essentially, or should be, then that can cause quite a lot of problems. So if we're then telling that patient to do what we refer to as Kegel, what a lot of people know as Kegel exercises, so pelvic floor, traditional pelvic floor exercises where you contract and then let go and do a combination of quick squeezes and longer ones. If somebody's doing that but they're not able to let the muscle go in between, we can cause them problems, because they can almost make the pelvic floor become more overactive. So if we suspect that, then we're obviously a little bit careful as well. And that's why general advice about pelvic floor exercises, for instance, over the internet is absolutely appropriate up to a point. But for some patients, there is a chance that might cause them some more problems.
So that's really important information to know, isn't it? So, you know, we never talk about that. You know, I don't often hear that you can't switch your pelvic floor off. Oh, wow. Okay. So then that's creating a whole other set of conditions, isn't it?
It is. And a lot, you know, I mentioned about us seeing quite a lot of patients who have a degree of pelvic pain, and quite a lot of those patients will have some dysfunction around their pelvic floor that's whereby it's potentially overactive. So those in particular we're, you know, mindful of, and it's essentially kind of over tension within the pelvic floor. But you know, if anybody has a sort of global pain condition as well, it may be that their pelvic floor is also you know, is behaving dysfunctionally, I guess is the best way of putting it.
And so, you know, having the internal examination so that you as the patient can feel what you're talking about, and then you as the clinician can also feel. So feeling it becomes vital, doesn't it? Because that's really introducing you to the sensation of what it is you're looking for. Because how do you know, if you're used to it being switched on all the time, you will have no idea what it feels like to be switched off. So
no, absolutely not. And also, you know, the patient you can't see your own pelvic floor. So it's a completely alien thing for many people. You know, we haven't grown up talking about the pelvic floor and what it is. So we're suddenly asking people to squeeze it and contract it. And, you know, it's perhaps unsurprising to me, but maybe surprising to a lot of people, how many people come in and think they're doing pelvic floor exercises correctly, when in actual fact they're really not. So some of them are actually pushing downwards, which is not necessarily particularly helpful for certain conditions. And then some are just massively pulling in their abdomen and their glutes, so their bum cheek muscles, if you like, and also holding their breath, which again isn't always particularly helpful. So, you know, quite often we see patients who come to us and say, well, I've been doing pelvic floor exercises and it's not working, it's not helping. You know, luckily there are absolutely quite a high percentage of patients who can help themselves and do pelvic floor exercise on their own, and they be helpful. But there's also certainly a percentage for whom that's not the case, and they need some clearer guidance and feedback on what is going on and isn't going on with their pelvic floor. And then also in terms of how you make the exercises harder, etc., over time, because typically and historically you were often told, oh, go off and do, you know, a set of 10 and do that however many times a day or however many times a week, and essentially the pelvic floor is like any other group of muscles in the body, and we need to train them appropriately. And we work to something called overload, which is where we actually damage the muscle in order for it to grow back stronger. And so if we're not challenging the muscles sufficiently, then also we'll see an improvement initially, and then things will plateau over time. So that's why some sort of clear and individual guidance can obviously be really helpful if somebody's tried some things themselves and it isn't making any progress. It doesn't mean that that's not going to work for you. It just means that, you know, care can be individualized and can be hopefully more effective.
Yeah, so really important to seek professional advice, isn't it? Actually, you know, and get a referral.
Yeah, and obviously I work in the NHS, so I know, you know, this should be available on the NHS in the UK. Obviously across the world things are different and have their own different health services, or whether it's private or whatever. But yeah, they're in the UK, they're obviously private pelvic health therapists, and then but then on the NHS this is available. So you know, not all GPs are aware necessarily so well of where we are located, but that there is going to be a service available in the area for you.
Yeah, so if you know that that's something that you're struggling with, then you can impress upon a doctor that you'd like to see somebody,
Yeah.
you know, who is a pelvic health specialist. You know, that's really important, isn't it? So
Yeah.
I think we've covered urination pretty well, actually. I think that, you know, so I'd quite like to go on to pooing now, please, because I think, you know, those two things can really go hand in hand, can't they? And you know, a problem that can kind of come around from kind of very, very early days is, you know, you're at school and you need to have a poo and you need to have it really quickly, and there's loads of kids in the, you know, in the toilet, so suddenly it kind of becomes a thing. So you're either going way too quickly or you're not going at all. And so, you know, over time, you know, pooing in public places or, you know, having to go can become a thing. And so I think it's important to kind of, yeah, maybe just unpick that a little bit and see kind of how those stresses can manifest, and, you know, and what can be done about it, because, you know, like you were saying earlier, it's all repairable if we have the information and that's right for us. So yeah, if you could just speak a bit more about that.
Yeah, certainly. So just to say, to start with, obviously there are certain circumstances. For instance, if your bowel habits just suddenly change, you know, you potentially do need to seek medical advice just to get that checked out or confirm that they're happy with that. Another kind of, you know, red flag signs like suddenly bleeding from the back passage and or sorry, in your stools and things. So yeah, obviously consider those things. But yes, as you mentioned, I think even more so, pooing is sort of a bit of a taboo subject, and we definitely see that over a lifetime certain people have you know, developed habits, which, as you said, are often sort of come at quite an early age. And one in particular is definitely this sort of avoidance of using the toilet, or avoiding what we refer to as the call for stool. And that should ideally, if our bowels are quite happy and quite regular and we have normal kind of transit of our bowels, then sort of on a fairly regular frequency, and for a lot of people sort of in the morning we should get a call to stool, and then we should empty our bowels. Now obviously there's a wide variation, which is normal in terms of how frequently people empty their bowels, but if you over time are, for instance, avoiding that sensation that you need to go, it gradually sort of over a period of time stops telling you. And then if your stool's being retained in your colon before it goes down into your rectum, then more and more water is absorbed, which will essentially make your stool harder over time. So then when it comes to you really needing to empty it, it's potentially going to be also harder, because it's got less water in, and then that can bring its own problems and difficulties in terms of constipation and the feeling like you need to strain to empty your bowels. And we spend a lot of time as physios talking people through, like, good positions on the toilet and the best technique for emptying your bowels. And some people look at me very strangely, because they think, what? Like, no one's taught me to empty my bowels. We just get on with it as a baby and off we go. And yes, that is the case. But in actual fact, a lot of us aren't emptying them in the most effective way. Particularly Western toilets aren't designed that appropriately for how our body wants us to empty our bowels. So there's all sorts of factors that can contribute to how easy or not it is. And if we are then having to strain, that puts quite a lot of downward pressure, a lot of pressure onto our pelvic floor, which can affect its ability. Our pelvic floor needs to be able to relax and let go in order for us to pass a stool. So again, if we also have other problems with our pelvic floor or pelvic pain, if we have that overactive pelvic floor that we spoke about just previously, then that can sometimes be also a factor in this sort of problems with emptying our bowels. So yeah, there's potentially lots going on, and lots of sort of general advice that people can definitely follow to try and make their bowels just a bit more regular and a bit more happy in general.
I mean, it seems mad to me that our toilets aren't designed for our bodies. I mean, that just
I know it is
bonkers.
mad. Yeah. So they are essentially sit us too high. So ideally, we should have our knees higher than our hips, and our Western toilets, and that is not the case. So in a lot of places in the world, people squat right down to empty their bowels, and that's actually physiologically what we're designed to do. So if you put your hips higher, then the kind of transit is just not as easy. So a simple thing of actually elevating your feet and putting your feet onto a small stool, and having them far enough apart, or even just a couple of toilet rolls, completely changes your position on the toilet, and then slightly leaning forwards also can help with that. So sometimes even just that is a game changer for some people who are struggling with their bowels, and it's quite a simple thing, but it can have quite an effect.
Yeah, I would absolutely say that, because as you describe it, and I've suggested to my clients to use them as well now, because it is a kind of, it just completely takes the stress off everything. So I've noticed that I had a client who had really bad piles, and actually using the poo stool has completely changed. I mean, she doesn't get them anymore.
Yeah.
So, I mean, and that's just by elevating her feet up. I mean, that's incredible. Because she was bleeding and having all sorts of problems and really, really awful discomfort. And so taking the strain out of it, so allowing gravity to do the work, has completely, changed things for her.
Brilliant. Yeah. That's
And so yeah, that kind of information it's not out there, is it? We have so much of our normal domestic stuff that looks normal, and actually it's really not. It's unhelpful and causing all sorts of issues potentially. So.
Absolutely. There's actually a really good little clip on YouTube by an Australian pelvic health physio who and it's years old now, but I give it out to a whole load of people because she goes through the kind of the ideal technique, if you like, including kind of the breathing technique as well, so that you avoid straining. So I'll make sure that that's passed on, because it's quite a useful little thing to watch for just a
Oh,
couple
yeah,
of minutes.
that's great. If you could send me that link, then we'll put that into the show notes when it gets sent out, because I think people will really, yeah, I think people will really benefit from that. And that kind of information can kind of just be like wildfire, can't it? Once one person has had a really good experience, they're telling everyone, like, you gotta get yourself a stool. Because yeah, I mean, I mean, there needs to be ease, doesn't there, around that? Otherwise, I mean, yeah, we can cause all sorts of trauma.
Yeah, I mean, and emptying a bowel should not be a difficult thing. It shouldn't take us hours and hours. Equally, obviously, it can go the other way. But yeah, if it is, then there's often something that's not quite so happy.
Mm.
Yeah.
Because the other condition is feeling like you haven't really finished. That also is something, isn't it? So you don't feel like you've kind of completed in a way. Yeah, so that's another issue, isn't it?
Yeah, and that can have multiple causes, but yes, it is something we very commonly see. It's quite often that's something that people won't kind of offer up to you. But yes, when you start digging and asking a bit more about their bowel habits, that's a factor. And for women, as I said, there are multiple causes, but for women, quite often that can be related to a pelvic organ prolapse. So that is a pelvic organ prolapse, for anyone who doesn't know. And I do hate the word prolapse because I think it sounds a bit sort of terrifying. But essentially, what it's referring to is where one or more of your pelvic organs, so your bladder, uterus, and your bowel, are sitting in a slightly different position, basically a little bit lower than they did at one time. And if that is if that's often associated with a degree of sort of weakening within the pelvic walls, the pelvic floor, and associated connective tissue. And what that means is that organ can then sit a little bit lower and essentially bulge down into the vagina. So if somebody is describing a sensation of heaviness, dragging, a golf ball in my vagina, discomfort, period pain, that maybe gets worse towards the end of the day, maybe some back pain, that's quite typical of this sensation of prolapse. And if that's happening at the back wall of the vagina, where the rectum is sitting, then essentially the rectum can bulge into that back wall and create that sensation that they feel like they can't fully empty their bowels. And a lot of women work out for themselves that actually if they apply a degree of pressure either around their back passage or under their kind of perineum, so between the front and back passage, or actually for some women, they work out that if they apply a pressure into their vagina towards the back, they can do what we refer to as splinting, and that basically is improving that kind of positioning so that the bowel can then empty a bit more effectively. And there actually is a device made. There's a device for everything now, isn't there, that's kind of helped that sort of situation for women as well. But it's quite a common thing that women will describe, and it's not always associated with prolapse, but that's definitely would be raising my sort of thoughts that could be going on for that particular patient.
And I think prolapse is probably a lot more common than we think. And like you say, the word is a little bit scary for people. And that kind of bearing down of everything can really cause, traction, can't it? And pain and chafing and
and it can cause a lot of worry, because initially, like, again, it's not something that at least people are often vaguely aware of what incontinence is, but prolapse, there's actually quite few people, even if you've had a baby, who are sort of aware of what it even is. So if you suddenly feel something in your vagina, you know, it kind of conjures up real fear about what's going on.
Yeah.
And the reality is, we think that, you know, an awful lot of really quite young women who've maybe not even had children have got a very slight degree of what we refer to as kind of a clinical prolapse. So it comes in, you know, varying degrees, absolutely. But if somebody's describing a sensation of that sort of feeling of coming down, then it's likely that to some extent that's what's going on. And you're absolutely right, it's really common, and it often will go hand in hand with either bladder or bowel problems, and that may be associated with which part is coming down. So for instance, if it's, we've spoken a bit about what happened if it's kind of more to do with the bowel, but if it's the bladder, somebody might, you know, the urgency we described, that can be associated with prolapse, because the bladder's getting a bit more irritated because it's sitting a bit lower down, and often you know, women also might describe, similar to the bowels, that they feel like they can't fully empty their bladder, or they're having to stand up and sit down and do a bit more. That kind of scenario can also be associated with prolapse.
And the remedies, you know, for prolapse, is that something that, you know, you can do as a patient? You know, is there exercises, or how would you suggest some? I mean, obviously everyone's individual, but you know,
Yeah.
in a global way.
Yeah. So I think the first thing to say is that everyone is different, and I think everyone's nervous system is different as well. So I've seen patients who have what I would refer to as a really large prolapse, and they're barely even aware of it or troubled by it at all. And then other patients who have clinically what is a very mild prolapse, but they're really troubled by it. So, and that can absolutely relate to other health conditions, or what their nervous system is kind of heightened to or aware of as well. So, and I think some of those women feel like they're not heard because they've gone to see maybe somebody else, and they've said, oh no, you've not got a prolapse, or you know, it's really mild, go away, kind of thing. So I think the first thing is to say it's really important to listen, because you know, everyone's symptoms are incredibly real. And yes, there is an awful lot you can do. I mean, you can do nothing at all if it's not troubling you. No one ever died from a prolapse, but it, like with everything else, it can significantly affect your quality of life. So pelvic floor exercises, we do know there is evidence to support, good evidence to support that in terms of improving symptoms, and there is general advice around bowel function, quite a lot of what we've talked about already. But essentially what we don't want to do is create more and more downward pressure that isn't sort of controlled with support. So if we are consistently straining to empty our bowels, which equally can obviously happen in association with a prolapse, then that's a factor. So definitely getting somebody to optimize the bowel function, lots of fiber, not avoiding drinking, you know, those sorts of things. Maybe things like flaxseed or linseed, which we know, you know, has a beneficial effect on our bowel function, etc. So sometimes things like that, but essentially, and obviously the defecation positions on the toilet, etc., that we've already talked about. Weight is likely to have an influence, because essentially it's just creating more pressure. Obviously that can be a tricky thing to firstly to discuss with somebody, but also you know, it's not as straightforward for an awful lot of people as just, you know, losing weight. That can be really challenging, but that may, you know, may be influential to some extent. And then there are also other things that can be considered. We talked a bit before about menopause, and one of the effects of less estrogen can be on the tissues in the vagina and the pelvic floor. It can essentially make them less kind of frailer, more vulnerable, more irritated. So if we can give those tissues some more estrogen locally, that can sometimes have a beneficial effect on prolapse as well. And that's something that I think we're becoming more aware of. Now, that I'm obviously not a prescriber, I'm not a doctor, so you need to have that prescribed, albeit you can now get it over the counter in certain circumstances in the UK now. But it's not equivalent to taking HRT or having transdermal HRT, because it's essentially localized to the pelvis, so it doesn't come with the same set of side effects that we're more consider with HRT. So that's something that might be appropriate as well. And then there are other measures such as something called a pessary. Now, a pessary just refers to something that you put inside, and they come in various shapes and sizes. The ones that in the UK, the GPs in primary care normally have are called a ring pessary, which essentially looks a bit like a round bangle and comes in various sizes. And that is something that can be inserted by a health professional, although you can sometimes be taught how to put it in yourself, and it can sit where kind of the cervix is, and essentially lift things up and provide support. If it fits well, you basically shouldn't be aware it's there. It can stay there for up to 6 months, and then it will be changed again, and they can be life-changing, either as a short-term solution while you're working on other things, or possibly waiting for surgery if it's more of a long-term thing, but they can be really effective. The trouble with them is it's not akin to kind of sizing somebody up for shoes. Unfortunately, we're all different sizes, and obviously because we're examining internally, it's not quite as straightforward as saying, yeah, you definitely need this size. So there's sometimes some trial and error involved, which some patients understandably don't want to, if it could, there's a chance it could be uncomfortable, or the chance it could feel like it's going to come out. But if you do get the appropriate size, then that can definitely be really, really effective for a lot of patients. And then obviously there is surgery. I'm obviously not a surgeon, but if you want me to mention anything about that, then I'm happy.
I think that would be really useful, because often that's the kind of way it's going, isn't it? You can live with your symptoms for so long, and you can do the ring, and that can be life-changing, but they're all, you're potentially, aren't you, going towards hysterectomy, I'm guessing. So yeah, that would be great to approach that, I think.
So yeah, and obviously every area is slightly different, every surgeon is slightly different on their approach. But yeah, surgical management of prolapse is done on the NHS. It's obviously done privately as well, and can be really, really effective. So there's a high success rate, but there's also potentially up to 30% recurrence rate. So for that reason, it's something just to open someone's eyes to, obviously, before signing up to. What that means is that it often will be effective for a period of time, but the recurrence of prolapse, either the same kind of prolapse or one of the other pelvic organs moving into a different position, is quite a risk. And for that reason, often in practice, the other more conservative measures will absolutely be considered and done first, because it's probable that your first surgery is probably likely to be the one that's going to be most effective, purely because there's more tissue to work with and not sort of scar tissue, etc. So yeah, you might find that the surgeon will say to you, we'll try these things first, and then if this doesn't work, we'll consider that. And certainly for the sort of younger women, it wouldn't be considered, certainly obviously if they haven't finished their family. And you'll often find the surgeons will say, let's hold off a bit and see what we can work on in the meantime. Hysterectomy is one of the options, but obviously that is if the uterus is what's coming down. So a hysterectomy doesn't always need to be done, but you might find a surgeon sort of consents for a hysterectomy as well, because under anaesthetic they can best work out whether the uterus is affected also, and then there are other options, and in the UK there is no vaginal mesh surgery done. In the NHS that pretty much wasn't done anyway, but I think a lot of people are aware of the kind of scandals around that, where it was largely done privately, and that is not done for any prolapse surgery in this country. So that's important to say.
Yeah. And if one is opting for hysterectomy, then obviously that's going to throw you into menopause if you haven't already been through it. So there's a big impact there, isn't there, to consider. So it's well worth traveling through all the exercises, doing all the other options, and that really being the last sort of bastion, I would say, probably, to
and if it's so they could have a surgical menopause, but often if it's done for prolapse, they would spare the ovaries, so you don't necessarily go straight into menopause, but it will have potentially still an effect on your hormones. But you're absolutely right, it's something to be considered. And again, we would obviously encourage people to engage with the conservative measures as well, persist with their pelvic floor training, etc., because the better shape your kind of pelvic floor and everything's in before surgery, the likely chances, the best recovery afterwards, and hopefully you hold off that recurrence or the possibility of recurrence afterwards. And it is major surgery, even though it's often done vaginally rather than via an incision in the tummy. There's still quite a long recovery period, so it's certainly not something to be taken lightly, but equally it can be absolutely life-changing for those women who have tried those other options and not got enough relief.
Yeah, because it's also, you can get your prolapses sorted out, but you will still need to be doing your exercises. So it's kind of like you can have your surgeries, but you're still going to need to make the effort, aren't you? You're still going to need to do the impact with your pelvic floor, and
and there is even a chance, and I don't mean to speak negatively, because prolapse surgery can be life-changing, but there's a chance in some circumstances that, if, for instance, a bladder prolapse can almost disguise some incontinence because of the position things are sitting in. It almost can kind of get obstructed. It's maybe not quite the right word, but it's in a different position. So if you imagine you then lift the bladder back up and lift it out the way, then sometimes you see an emergence or a worsening of stress incontinence afterwards, which can be a real shock to patients if they're not really aware that there's a chance that could happen, which is why again, targeting the pelvic floor and making sure that's working as well as you can is really key.
Because I think that's that's potentially the empowering thing, is that you have involvement and you can make those changes by doing that. They really do work. There's and it can be a remarkable kind of improvement to somebody's life. So just by making that commitment, and seeing, being able to kind of feel the improvement and see the improvement, just makes you, encourages you to do it more, I think, doesn't it? For it to be a dedication to doing.
I think so. And I think for a lot of patients, it's maybe even that they don't change their symptoms or they don't stop entirely, but the fact they've just been sort of soldiering on, maybe not seeking any help, the very fact that they've been able to then share that with somebody and get some help, I think sometimes it can have a dramatic effect, even if in reality they're still getting some problems. I think it's really true that like a problem share is a problem halved, because I think if you've got a strategy in place and you've got some chance of some positivity and positive results, I think it's really key, isn't it? Because you feel like you can then help yourself and you're a bit more in charge. Whereas if it's a condition that you're just suffering with in silence, then you're much less likely to feel empowered.
And I think the surprise would be that you're actually being listened to, that you're not actually making it up, and you're not being an awkward person, and that there's someone who will kind of say, well, there's things we can do about this, and yes, actually that does sound quite bad, sounds like you're struggling with that, so for that to be recognized.
And that's why I think, absolutely no disrespect to GPs, because I think they're amazing and doing a very challenging job. But that's why, for instance, obviously I'm a physio, so I'm going to talk about physio, but we have we have so much longer with our patients than, for instance, a GP does. So I feel like we're able to listen and give the time to hear their story. And as you say, I think that's so important that somebody's heard. Whereas with the best will in the world, a GP has 10 minutes, and it's very easy to then feel rushed and not fully heard. So knowing that there's somebody else out there that you can request to see, for instance, and also knowing that there are lots and lots of resources out there to help, I think is really key.
Yeah, and the service continues, doesn't it? So my understanding is that once you're in the system and you've seen somebody, say your symptoms have improved, and then maybe like a year later or whatever, you may find that the symptoms are kind of, coming up again. You can just check back in, can't you? You can, because once you're in, you're in. That's why it's so important, isn't it? So that you'll always have access to that help.
I mean, I really hope so. Yeah, every area is different in terms of how easy it is to access services. But yeah, I mean, in our case, yeah, we have a sort of almost open door policy for a period of time. But yeah, once you know who's out there and what services are out there, then yeah, there's no reason why you shouldn't be able to access that. And for instance, in the NHS, but also privately, you can then often be referred directly by your clinician into, for instance, the Urogynae team or secondary care if things aren't going so well.
Yeah, which is great. It's just kind of having the right person to ask the question to, isn't it? That is so important. Well, I'm looking at the time. Oh my gosh. We've got time for some questions. Wow, that conversation went really quickly. Thank you so much. It was so informative. We've got a couple of Jan's asking, some patients resist drinking enough water because they're worried it will increase their trips to the loo, with consequences for their general health. Do you have any advice that might encourage them to stay hydrated?
Yeah, yes, Jan, that is a real problem, especially with those patients. Well, either stress or your urgency incontinence, but we're often very clear to those patients with urgency in particular and say, if you avoid drinking, you essentially make your urine more concentrated, and that can actually irritate the wall of the bladder further and drive the urgency. So although it might seem like a logical approach, it can actually make the situation worse. So I think sometimes if you explain that to the patient, that can be helpful. We'll often also look at what they're drinking, because there is some evidence around particularly caffeine and bladder overactivity and urgency. So for some patients that can be helpful, sort of optimizing other kinds of fluid rather than caffeine. But yeah, you're absolutely right. It can be a big problem, and obviously if it's really not good for your general health or your bowel health to then be avoiding drinking.
Great, that's a great answer. Thank you. Hilary asks, will a hysterectomy make a person more vulnerable to prolapse? Prolapse from the bladder, that is.
So to some extent, possibly, because you can also get what's referred to as a vault prolapse. So that's where the tissue that's essentially was around the uterus after it's removed can also come down. So it's certainly not a sort of final solution to everything. You can still get a subsequent prolapse. So again, it's about weighing up quality of life, and whether you're prepared to risk the possibility of that happening. And recurrence obviously doesn't happen for everyone.
Yeah, well, that's great. There's been some really useful information there, I think, and I'd really like to get any kind of tips from you, links, any information that you think would be useful with regards to what we've mainly focused on today, actually, which I think has been really thorough and informative. Thank you. And yeah, if you could email them to me, I will put them in the show notes for everyone, and they'll be you'll be able, because I think yeah, we don't get the chat box when it's recorded. So yeah, that would be really great. And then the information is there for everyone to get. So, well, we've just had one more question. So, Hillary asks, is it true that sucking the thumb is directly associated to tensing the pelvic floor, and can it be used to strengthen it?
I haven't. Do you know what? I haven't really heard that. Now, I might imagine that. I definitely wouldn't say it could necessarily be used to strengthen it, but I can imagine that could be the case. There's quite a link between tension in the jaw and then tension within the pelvic floor. So there's quite a link there. So if you have kind of jaw problems, there is, potentially more chance that you've also got some tension in the pelvic floor. So I can't quite answer the thumb one, but it could be the same, the same mechanism or the
Yeah,
same
well,
association.
yeah, and that's a really good one to end on. So I'd really like to thank you, Beth, for your time today.
You're
I
welcome.
know you have a very, very busy work life. So yeah, much, much appreciate it. And yeah, thank you for all the information. It's been really, really useful.
You're welcome. Yeah, it's great. I'm always happy to try and help anyone. So yeah, thank you.
Oh, bless you. Thank you so much. We'll say bye for now. Okay.
Thanks.
Thanks so much.